So wanted to share with you a little bit about what Spectrum Health is, how the span that we have here in Western Michigan. We service about 14 counties here in our primary service area. We have approximately 14 hospitals and over 200 ambulatory locations. And we really service an area that's rural, urban, suburban, so a wide variety of settings. So this is a very busy slide, and certainly don't want to spend too much time on this, but I do want to draw your attention to the fact that we do have 220 ambulatory sites across our system. What this means is that we have a fantastic opportunity to integrate behavioral health across a really large span of our service area. But also it presents a lot of challenges because standardization in processes certainly can be challenging given the large nature of how many sites we have. The one nice thing also about Spectrum Health is that we do have an insurance arm to our system, which is Priority Health, and we have about 1 million members that we serve with our insurance product. All right, so let's get into the thick of things. So I'm here today to share with you Spectrum Health's journey to integrating behavioral health into the medical services we provide. While I want to focus on our ambulatory setting, of course, this work spans all delivery settings. I want to start with why Spectrum began this journey and a little bit about what is in the literature. We certainly know that there's tremendous medical and mental health comorbidity. This comorbidity leads to worse medical outcomes with increased risk factors, decreased ability to cope with distress of medical illness, and treatment noncompliance. We know that over half of all Americans will have mental health conditions sometime during their lifetime, either primary or secondary diagnoses. Furthermore, 1/4 of adult Americans will experience a substance use disorder in their lifetime. And let's talk about our kids. Behavioral health diagnoses were the 4th most common reason for admission to a hospital in this country in 2009. And we also are seeing alarming and increasing rates of suicide in our adolescents. So when physical conditions and mental health disorders co-occur, they are risk factors for one another. The presence of one can complicate the treatment of the other. Individuals with mental health disorders increase likelihood of chronic conditions such as diabetes, asthma, stroke. For example, having comorbid depression and coronary artery disease triples risk of mortality from a future heart attack or other heart condition. There was a study in the state of New York where 70% of Medicaid patients deemed high risk for hospitalization had a history of mental health disorder. By 2020, the World Health Organization predicts that depression will have the #1 spot as the global burden of disease. And the literature really goes on, and we can spend all day talking about it, but I think this shows why this is such an important situation to address today, and why we need to put into place different interventions so that this can be addressed for the future. So let's talk a little bit about cost. Because of all of the reasons that comorbidity drives up cost in the medical healthcare system, we really do need to consider integration. We are seeing the medical health system as the #1 gateway for folks coming in with behavioral health conditions, and we see this particularly in primary care and our emergency department. 75% of patients with depression indicate a physical complaint as the reason they seek health care. Intermountain recently published a study in JAMA showing that an investment of $22 in integrating behavioral health can save $115 of savings per patient. So we know that integration can help from a cost perspective. And really, we know that comorbidity, why is the cost so high? Well, we know there's increased healthcare utilization, there's greater ED utilization, longer length of stays in our hospitals. So we have an opportunity to address cost as well. So why not screen or identify in the medical setting and then just hand off to our behavioral health partners in the community? Well, the mental health system is fragmented and wait times for services can be very long. There's also a shortage of behavioral health providers. The shortage of psychiatrists nationwide is real and recruitment can take years, and that's certainly been our experience here at Spectrum Health. For Michigan specifically, we rank 41st out of 51 states and districts in terms of prevalence of mental illness, which is very high, and access to care, which is very low. There's also clear separation from medical experience in our behavioral health system, which is complex, knowing that the high comorbidity of medical and behavioral disorders exists. And certainly stigma. This is very much a reality today. And maybe if we provide access to behavioral health care within medical settings, this will feel less stigmatizing. Resistance to treatment. We know that already maximally stressed patients are not going to go to another provider in a corner of the city to get their behavioral health care separate from their physical care that may be difficult to navigate. So these patients are already treated in our medical system, so why not go ahead and leverage that opportunity to heal the whole person, both behaviorally and medically. So this is our integrated behavioral health model here at Spectrum Health. This model is really the integration of psychiatrists, psychologists, and clinical social workers into primary health or other clinical service lines. And we do this by embedding social workers where we can at various locations, and then also utilizing telemedicine and other technologies to provide access to other professionals in those settings. So we address behavioral health needs of patients throughout the care continuum from wellness to post-acute via these three coordinated steps: screening, triage, and interventions. Screening takes place in primary care and other specialty practices, and I will get into this a little bit more later on. Care triage is done by licensed master social workers that here at Spectrum we call behavioral health specialists. And what do? Well, they treat the they provide the listed here services. So biopsychosocial assessments, brief psychotherapy, crisis management, systematic case review, care coordination, linking to community resources, and of course, referrals for other interventions. I do want to comment on systematic case review. So this stems from models that some of you may be familiar with, such as Impact, Diamond, and Compass. Through systematic case review, our social workers present patient cases from their settings to a consulting psychiatrist who provides recommendations on treatment and medication management. The social worker shares these recommendations then to the referring provider or primary care provider, who then decides to prescribe the medication. So the psychiatrist does not actually do any of the prescribing. In this process, we actually have one psychiatrist who is able to review 8 to 12 patient cases in an hour. So when we think about the traditional model, a new patient appointment with a psychiatrist can last 1 hour. So obviously the systematic case review process is a lot more efficient, providing access to more patients in a more timely manner. And it does also allow social workers to bring cases back to SCR. So it's not just a one and done. There can be follow-up, certainly if a patient is showing different symptoms or not responding well to the proposed previous recommendation. And then, of course, we have other interventions, which include direct psychotherapy or one-to-one psychiatry treatment. We do also provide psychotherapy and psychiatry visits using MedNow, which is our telemedicine medium. This is especially helpful in our more remote areas where psychiatry access is even more scarce. In these environments, patients will go to their local primary care clinics and can see a psychiatrist via video visit. And we do also offer teletherapy, which allows patients to receive psychotherapy from their homes or other convenient locations. So we're saving them drive time, you know, reducing the amount of time they have to take off work, etc. So the feedback we've received with our telemedicine mediums has been extremely positive from a patient perspective. So the model here shows just a sample of our encounters in each of the 3 components. This is showing data for 7 sites and really shows that for 34,000 patients, about 33% required triaging, 14% required additional interventions. Really paying attention to the numbers here has allowed us to scale this model appropriately as we expanded into more outpatient locations. So this is Spectrum Health's journey. We initially started with 1 site several years ago. We embedded a social worker in a primary care location, and our existing division chief served as the systematic case review psychiatrist. We did a lot of learning and toolkit development, inclusive of providing scripting to staff and providers of how to have conversations with patients about the additional behavioral health services that we're offering. We made posters that we displayed in our lobbies, indicating to patients that we would be conducting a behavioral health screening in their visits because this is something new, and so we wanted to prepare them for that. And the toolkit really became more and more robust as we went on. After the initial pilot, we received approval to expand to 10 primary care sites. So we went ahead and hired more social workers, and were able to offer that behavioral health integration in more practices. And then after that, we were granted the comprehensive primary care plus track, and that was track 2, which allowed us to embed an additional number of social workers, and so 27 primary care sites were live with the integrated model. After this, we really wanted to go obviously primary care wide, so that encompassed 78 sites. We don't currently have all 78 sites with embedded social workers, but we've been extremely creative in how we are managing that issue. So we've created a social work pool where for those primary care sites that do not have social workers, they are able to send or refer patients to that pool, and we have a team of social workers that are able to do kind of one-time coordinated visits to coordinate services for those patients and refer to appropriate settings. And then we, of course, wanted to continue integrating behavioral health outside of primary care as well. And so that's where we are today. We do have social workers embedded in some service lines such as cardiology, oncology, neurology, pain, transplant, but we are still optimizing that model in other service lines. And we were very deliberate with not making this too prescriptive. We recognized through change management processes and evaluating adoption that really service lines that are pulling and wanting to have social workers, the program ends up being much more successful if they come to us first because they've heard from their colleagues, maybe in other service lines, of how well this is working and improving their outcomes. And so that's been kind of a lessons learned for us, not to say, all right, everyone's going to now screen for behavioral health, because that message is not well taken, as you can imagine. So these are the screening tools that we're using. I'll start on the right. All of our primary care sites and some specialty sites are using the PHQ-4 as an initial screener for depression and anxiety. That screener has 2 questions for depression and 2 for anxiety. Depending on how patients answer, if they are positive, for one or the other or both, the patient is then continues on to answer additional questions for depression and anxiety via the PHQ-9 or the GAD-7. And then on the PHQ-9, the 9th question is a suicide question. And so obviously if a patient answers positive to that, we want to address that. And so we have implemented the Columbia questionnaire as the next step if a patient discloses that they are having suicidal ideation. From a workflow perspective, how we have embedded this is that the PHQ-4, the PHQ-9, and the GAD-7 are conducted by the medical assistant during the rooming process. So even before that patient sees their provider, the medical assistant is able to conduct those surveys and input the results into the EHR. Of course, suicide, if the patient does have suicidal ideation, then the provider completes the Columbia screening. And the majority of this is really embedded in our EHR. We recognize, obviously, there are lots of things that providers and staff have to remember, and so we want to leverage our technology to help with workflow so that folks don't have to reference other standard work, et cetera, when doing this screening process. I do want to comment on the left here, we have the Suicide Safety Behavior Kit, which we coined here at Spectrum as the Blue Envelope. We developed the Blue Envelope as a response guide for staff and providers when a patient presents with suicidal ideation. We found that oftentimes many are not very comfortable addressing this issue in our practices, and so we wanted a very easy tool for our sites to have when this presents. Initially, this toolkit was fully on paper, and then as time has gone on, we've begun embedding it into our EHR as well, and we're very much on our way to making it fully a part of our electronic health record system so that folks don't have to rely on a paper version of this. A little bit more about our Blue Envelope. So inside, we really wanted to make sure that this envelope was very easy and simple to follow. So the thing that is on every piece of information in this envelope is safe. We want to remind folks to stay with that patient after they've identified themselves as having suicidal ideation. We want them to know to go ahead and ask for help and alert others. So if a patient discloses this on the phone, go ahead and IM one of your colleagues so that you're not alone. Or if this happens in a room, go ahead and you stick your head out the room and ask for help. We really want folks to feel supported and have that second responder with them as they're addressing this concern. And then feelings, validate the feelings of the person, and then of course eliminate risk. So our Blue Envelope Toolkit has responder guides for initial, secondary, and provider clinician responders, which take them through guided steps to help them address the situation. For a 3-year time span, we've seen utilization of this toolkit increase by 600,000, and that's just because we've really made an effort to make the system aware of this toolkit. If you go ahead and round on any of our locations, you will see the Blue Envelope, and it literally is blue, at folks' workstations and in drawers, so it's readily available so that they know where they can access it if this presents. In 1 year, we've had 9,000 potential lives saved via the Blue Envelope or the Columbia screening that we have embedded in our EMR. We also, in this process of development, realized that there was a need to create an employee version. So folks were coming to us saying, okay, well, what happens if there's a colleague that discloses being with suicidal behaviors? And so we did go ahead and partner with our HR department to develop an employee-specific Blue Envelope, and it obviously is a little bit different than our patient version. We partner with our employee assistance program to go ahead and get our employees set up with treatment right then and there when this disclosure is made apparent. I do want to comment, so the Joint Commission recently released National Patient Safety Goals for Suicide Prevention. I'm sure many of you on the phone are Joint Commission sites, perhaps, and so these goals are have to be in compliance by July 1st of this year. So not a lot of time left for us to go ahead and comply with all of them, but nonetheless, all of the work that we've done on suicide prevention here at Spectrum has gotten us a really great foundation to being ready for July 1. Not all of our ambulatory sites are Joint Commission accredited. Our hospitals are, and so we are really taking this opportunity to align all of the great work around suicide prevention across all of our delivery settings so that suicide prevention has, the same content, patients are getting the same experience, we're using the same tools. For example, our safety plan tools looked different in different settings, and so by getting ready for this Joint Commission compliance date, it's giving us an opportunity to really look at alignment. As I mentioned previously, leveraging technology is very important to us. We don't want to rely on human error or folks having to remember what to do next. And so this is an example of how we're embedding guidelines into our EMR. Here at Spectrum, we use Epic. And last year, we went ahead and aligned our EMRs. We had Epic and Ambulatory and Cerner on the inpatient side. And last year, we went ahead and moved to Epic, which is very nice because now we can, again, align the work that we have in ambulatory with what folks see in the inpatient settings. So you can see here that we have the scores available, the PHQ-4, the 9, the 7, if patients did take those during their visit. Also, we have the Columbia screening embedded there. And then below that, you do have the level of risk table, which helps guide clinicians as to what level of risk a patient may be depending on how they respond to the Columbia screening. And below that, we have additional assessments to guide the provider to really assess further that patient and whether they are safe to be dispositioned home or whatever that next level of care needs to be. I want to spend a little bit of time on billing. There are a couple new codes actually for screening for behavioral health assessments. We went ahead and implemented the 96127 for our ambulatory sites. This CPT code became available in 2016, and we found that most payers are now reimbursing for it, which is great. So the way that we went ahead with billing is that here at Spectrum Health, we are really thinking that the PHQ-4, those first two questions for depression and anxiety, are a vital sign. Just like taking blood pressure, your height, your weight during that rooming process, this is mental health really needs to be a vital sign as well. And so that screening is included in our E&M charge. But the GAD-9 and the PHQ-7 are chargeable via this 96127 because it's really an additional assessment that we're doing with that patient. For the billing as well, we wanted to make this as easy as possible on our providers, and we were able to automate the code drop into our EMR so that providers don't have to remember to select it when they are closing that encounter. I do want to comment also that for the Joint Commission, one of the guidelines is to screen all patients presenting with a primary diagnosis of behavioral health with a suicidal screen. And in our ambulatory, when I was discussing our screening tools, you see that the PHQ-9 is not done for all patients. It's only done for those that screen positive for depression. And so one of the things that I think we're going to end up moving to for that compliance date of July 1 is to make that PHQ-4, our vital sign screen, a PHQ-5. And by that, I mean we would be adding the suicidality question from the PHQ-9 into the PHQ-4, making it thus a 5-question screen. And again, that would be really part of that E&M charge. It is a vital sign, and we want to know right off the bat if a patient is suicidal. So outcomes. These are outcomes for our original 10 sites. Before we continued on with the expansion, you can see here that social work impact. So the definition here of when a social worker was engaged is really, what did a social worker have at least one visit with a patient? And if so, then the patient's engaged with social work. And our average scores for the PHQ-9 and the GAD-7 improved with social work engagement. So this was extremely promising, and hence we were able to expand this model further. So this is just showing our A1C rates for those practices that had social workers embedded. You can see on the right, that first column is showing post-social work engagement. So lots of greens there, which we were happy to see. And then the column next to it was the scores of A1Cs for patients prior to their engagement with social work. So we know that comorbidity between mental and medical is high, and so by addressing our behavioral health concerns with patients, we're thus able to improve the medical outcomes for patients. So future state wish list. We certainly would love to embed our social workers into every primary care site and every ambulatory specialty location. Right now, we're not quite there, but we have creative solutions that we've worked to implement so that at least these sites that are doing these screenings have a support network for when these patients do screen positive. We do want to expand our psychiatry and psychotherapy access via provider growth. Obviously, with shortages, at least in psychiatry providers, we are moving to being flexible and allowing providers to work from other locations, so not on site. We do have some providers that are working, for example, in other states or other parts of the state, and they work with us purely remotely, and so patients see their psychiatrist via that telemedicine medium. We really want to focus on more training for primary care regarding the management of behavioral health. Our primary care providers really do see a tremendous amount of behavioral health in their practices, and yet their medical education didn't necessarily prepare them for this. And so we feel that we need to prepare them better. We have implemented quarterly webinars that are put on by our psychiatry behavioral medicine providers, specifically for primary care, because they are really seeing a lot of these patients. And referring to psychiatry and behavioral health is not always a timely option. We do have pretty considerable wait times for patients to get in, and so we don't want patients waiting that long, and primary care may need to start them on initial medications, etc. We would love to grow our data analytics to include more health outcomes and cost of care metrics. So we're well on our way in partnering with our insurance arm and our quality department to gain more data analytics, but certainly would love to do more of this in the future. We would like to develop real-time crisis support for our suicidal patients. We find that our practices having that blue envelope toolkit, they're very grateful for that, but sometimes they still struggle with, I really would love to have someone be available right then and there when I have a suicidal ideation patient in front of me, and we just don't have that ability right now. Our future also project includes standardizing substance use screening and pathways, and we've begun initial planning for that, but we have a ways to go on that. And certainly, of course, always optimizing workflows and relying less on folks remembering what to do and more so triggering the process within our electronic tools. So lessons learned with our integration of behavioral health. a phased rollout is really great because it allows us to learn a lot more about what expansion will mean and what toolkits we can put in place to make that expansion smoother. With having as many sites as we do, I think one of the reasons why we were successful is because we had a very robust toolkit with scripting and posters and education for providers, staff, and patients. Without that, I think we would have had a lot more difficulty with change management and just seeing success in the process. Definitely find a provider champion or several. Our division chief, Karen Taylor, often went to sites, especially in primary care, to discuss, what to do. A lot of providers, their hesitation is around, okay, now I know that the patient has behavioral health needs. What do? I have to address it, but I don't exactly know what to do next. And so she spent a lot of time walking them through what to do and where they could refer, what resources were out there, and this really was helpful. Developing toolkits inclusive of all those pieces that I had mentioned before, certainly something that I think helps success and integration. Leveraging technology and starting on data analytics early. This one in particular, I wish we had done a little bit earlier or had an earlier start than we did, but I think it's something that we are working on to improve. And then be patient. We had a lot of early adopters that were very excited to do this. In fact, there was one meeting I remember where we had a couple sites presenting because they were early adopters and had already begun screening their patients, and they were showing their great results and talking about the process, and they were really great champions. The audience was site leads of every other primary care site, so the majority in the room had not begun screening. And because those early adopters were able to share their successes and kind of diffuse the concerns that maybe other sites had, the team voted to include screening, even though they may not have had social workers embedded in their sites. And so that was a really huge win. All right, well, that concludes my presentation for today. I'm happy to entertain any questions if there are any, and so I think our lines will be unmuted. Oh, actually, I think if you do have questions, go ahead and chat, post them in the chat box, and I'm happy to answer them that way. I don't think we will be unmuting lines just because there will be a lot of noise in the background. So there's a question from Teresa. How do you handle limited English speakers? So we do everything through our bilingual translation services line. We essentially get them on the phone or on our iPads, and there's translation that occurs. And so the questions, the screenings, and then the entire visit where the assessment is conducted is done via that translation service. There's also a question, do we have bilingual staff on site? We do have some that are Spanish speaking, but because we service such a wide area, we do have practices that have high refugee populations. We do rely on that translation service. And for those staff that are bilingual, we do ask that they pass a test so to verify that they are able to medically communicate with patients. There's a question from Chad, are the social worker services billable and telehealth psychotherapy services reimbursed by insurance? So yes, social work services are billable. Those social workers that are embedded in the primary care sites are half-time doing psychotherapy, which is a billable service, and then the other portion of their time they are doing care coordination with care management codes. And then regarding telemedicine for psychotherapy, not all insurers reimburse for this, and so we only offer that service to patients if they have the payer that reimburses. All other patients can always seek that service in person. Chad also asks, if 96127 isn't covered and goes to patient responsibility, have you encountered patient complaints regarding this? We did initially. Thankfully, the charge is pretty low, and so it hasn't been too big of an issue. When we first rolled this out, we didn't have a decline option. In the EMR, we really wanted to encourage all patients to respond, but we did get some of that feedback that they weren't happy they had to pay for it. And so we did implement a decline button in our Epic system. And so patients, just from history, know that they will have these screenings. And if they want to decline, they can. We certainly encourage them to complete them. We have education that we've provided to staff, trying to encourage patients to complete it, and making patients aware that their mental health is just as important as their physical health. And so we haven't seen too much resistance after we provided more education from staff. So yeah. Beth asks, do you hire LISWs or LMHCs because Medicare will not pay for those? So we at Spectrum only hire the licensed master social workers for that reason. We do have some limited licensed social workers in the system, which obviously is a great gateway for that career trajectory to gain then fully licensed master social workers. The limited licensed social workers can see certain payers, and so wherever we can, we leverage them as well. Tony's question, we have tried billing code 96150, but not having luck getting payment since it cannot be a mental health diagnosis. Any suggestions? Through our assessment, we did not proceed with that code, so I don't know too much about it, unfortunately. All right, I think those are all of the questions that I see in the chat. If there are others, please don't hesitate to send them in right now.
Natalia, thank you very much for sharing your process and great information and taking the questions. And thank you to everyone for taking time out of your busy world to attend the webinar today. We hope to see you again on another webinar, and appreciate, again, Natalia, thank you so much for the presentation. Slides will be sent out after this, along with an evaluation, and please complete that and send it back.
Thank you, everyone.
This concludes our webinar today. Thank you.